Welcome, everyone. We're about ready to start our session, so I'm happy to have you join us this afternoon for improving FTD care in rural and underserved communities. We'll probably have a few more people jump in with us as we go along, but let's get started because we have a busy session and lots of really good content to cover. So we know that helping people with FTD to get on a path to finding appropriate care and support and learning about potential research opportunities starts with diagnosis. That remains profoundly challenging for people in cities and in areas rich in medical health and social services. In areas with fewer resources, it's even harder still. One aspect of equitable access to care is receiving well-deserved attention is addressing challenges of people living in rural areas or communities with limited resources. Today's panel, led by Andrea Denny of the Knight ADRC at Washington University, will explore efforts to improve dementia care and services in rural areas and how people facing FTD can benefit. So it's my pleasure to introduce Andrea Denny, who leads the Outreach, Recruitment, and Education Core of the Charles F. and Joanne Knight Alzheimer's Disease Research Center, or the Knight ADRC. She's also a social worker for Washington University School of Medicine and the Memory Diagnostic Center. Andrea is going to introduce several of our esteemed panelists today, and she'll be leading and facilitating a discussion around this really important topic. So Andrea, welcome.
Thank you. Thank you so much, Sharon. And thank you to AFTD for inviting us to be here. I'm here with some great panelists. And so I am going to just say a couple of things about myself and then get started. As Sharon already said, I work at Washington University in St. Louis, where I think some of you may be, and I know a lot of you are joining us from other places. So welcome. Besides being the social worker for the memory clinic, and I work to support patients and families, many with FTD and all sorts of other diseases, and leading the outreach and recruitment. Part of the outreach and recruitment we do is specifically to support really educating rural clinicians to learn more about how to manage and treat different dementias, including FTD. And I've also, for many, many years, about over 12 years, been a volunteer for the Alzheimer's Association, a sister association, I guess, doing a support group for spouse caregivers of people with young onset dementia. And so, as you can imagine, as you know, because FTD skews younger age than Alzheimer's disease, many people I've worked with over the years are care partners to people living with FTD, and just so near and dear to my heart. So, but that's enough about me. Next, I want to go ahead and introduce our first speaker and panelist. And please know that after we hear a little bit from each of our panelists, we really want this session to be meaningful for you. All of our panelists come to the rural support of people living with FTD and making it better from really different avenues. So I think your questions will help us use the expertise that we have with us today to get to what you want to hear. But anyway, so I want to introduce Dr. Debra Tann. Debra is an incredibly talented person and educator herself, and has turned her leadership skills more recently, as she's a doctor of education, to be the CEO of Reminiscent, which is a brain health organization that is trying to move the needle in rural South Georgia by conducting events that enhance dementia and brain health education. She also is a tremendous advocate at state and national levels to help. She really is focusing on trying to eradicate the healthcare disparities, which we know very much exist. And in fact, she was recently recognized and selected as a Bright Focus Foundation honoree because of all her amazing work. Today, however, she is here joining us. She may tell you about some of those things, but she is here to share her experience, her personal experience as a care partner for her husband with FTD, and to talk a little bit about how it was for them living, I think, in Valdosta, but in rural Georgia, trying to get a diagnosis and a support. So with the FTD diagnosis. Debra?
Huge. Thank you, Andrea, for that wonderful introduction. It's a pleasure to be before you this afternoon. I just want to be short and sweet in terms of information, very compact, if you will. I'm going to share just a little bit about Chris and I's journey with his FTD diagnoses. It was in 2019 that he officially got the diagnoses, and living in the South, the rural South at that. And I think this is important that we set the stage. Approximately 20% of Americans live in rural areas, and we only have about 8% of specialty doctors across the nation. And so that begs a very good point, and certainly the segue of what I would like to talk about. So back to Chris and I's journey. You know, it took a lot of digging, if you will. I spent about 3 years trying to figure out what was going on, what this thing. He was initially diagnosed with MCI, which is mild cognitive impairment. But I took about 3 years, if you will, just trying to better understand Alzheimer's, frontotemporal dementia, Lewy body vascular, Parkinson's disease dementia, trying to best understand what this looked like and for me, what it felt like, and wanting to know if others were experiencing it. And what happened was, it just happened to be around the time of COVID. So we were locked in for the most part anyway. So I spent a lot of time researching, and I didn't mind doing that because that's what I have done. That's my history. That's my background. Part of my earning my doctorate degree was researching information and digesting it and comprehending it and using that information to, better the lives of Chris. And I often say is his story is my story, and then there's our story. And so I utilize that time to really bode myself well with a lot of information. And this is what I want our audience to best know that was important to me. Now, this may not be applicable to everyone, but it was quintessential to me that I not get ahead of Chris's story. Chris had to be in a place, and I was waiting for Chris to become or to get into a place where he was comfortable with the story. I have and had during this time that much respect for my husband that I was not going to put the cart before the horse, if you will. So I spent my time researching, reading, digesting information to better understand the topic matter. And then at the same time, taking care of myself, because that's essential as well. And then eventually it came to a point, and I'm a woman that does pray. I want you to know that. And eventually Chris did come around, by which he began to open up just a little bit more. And once he started to do that, that allowed me to open up just a little bit more. So that's kind of how we got started with this whole thing. But fortunately for me, this doesn't happen all the time. I was able to take my skill set, if you will, and do all the things that were necessary. So when Chris did open up about his story, and when things became available unto myself, I had already did a bunch of work. I had authored a book about dementia because I was sitting on all of this information and I wanted to share it. So I authored a book. I launched my business. I was very active, if you will, in terms of taking part in this thing called frontotemporal dementia. And that's kind of how we got started, Andrea, and this is where we are right now.
Wonderful. We are just so pleased that you're here and you're here. I'm sure people will have questions for you. I know I will, but thank you so much, Debra. Our next panelist that I want to introduce is Sara Hill. Sara has been a nurse practitioner with Cox Health Neurology Group in Springfield, Missouri for 6 years, and has been a part of the Springfield, Missouri healthcare community for 13 years. She has a passion for supporting people experiencing memory and thinking changes. And in fact, she began a memory clinic, which is so cool, at Cox Health System 2 years ago. I first met Sara because, as I said, part of my work at the Night ADRC in the outreach is to do something called the Clinician Partner Program, where we bring in once a year rural clinicians to kind of get a mini residency for a day and a half or 2 days with CME included and travel and everything, to learn as much as we can about best practices in clinical care for dementia patients and what's going on in research. And now Sara and I are together as colleagues in another initiative. I don't know if any of you are familiar with echoes anyway. It's something that's used now internationally, started by a doctor that in a specialty practice that wanted to teach rural clinicians how to do what he did, so people didn't die on wait lists for his practice, waiting to get into a specialist. So we are part of a dementia echo with some other practitioners that uses teleconferencing to provide twice monthly education and case discussion with all sorts of providers, including community health workers on up to doctors and, nurse practitioners like Sara, to learn about how best to take care of our patients. And today we're asking Sara to speak about her experience as a clinician for people with FTD, and particularly thinking of those patients that come to her from more rural parts of Missouri. Sara?
Thank you, Andre, for that introduction. As Andre mentioned, I currently reside in Springfield, Missouri. I'm working in a neurology clinic that serves a rather large population, and the area includes areas of Southwest Missouri, Northwest Arkansas, Northeast Oklahoma, and Southeast Kansas. So we see a large range of direction here in kind of our corner. And so with the clinic that I currently work in, being a specialty office, we're often the last line to see patients prior to them receiving a diagnosis of FTD. And even then, it can continue to be a really long road to reach that diagnosis, as I'm sure Debra can speak to more if patients have questions regarding, or if anyone has questions regarding that. But FTD, like all other types of dementia, is a clinical diagnosis. So that means there is essentially no blood test, no imaging or scan that we utilize to diagnose this disease. And so this is one of the reasons that FTD is such a difficult diagnosis to give and receive when patients begin to have symptoms. So neurological workup can be helpful to diagnosis and can be a good starting point, especially for primary care providers when they're working to refer patients to a neurologist. As many of you, I'm sure, know, there's a very extended wait time to get into most medical specialties, and that includes neurology pretty significantly, actually. And so having this workup completed or started prior to that initial neurological consultation can really aid in receiving a quicker diagnosis. Otherwise, once you are seen initially, then, that's workup that we're going to be starting. And then that's just going to be more time that's spent waiting for answers. So this workup that we typically use and can be started again with primary care starts with a clinical assessment. And that doesn't just mean, doing a physical exam on these patients, but it also includes the history of present illness. So it includes what symptoms patients are having right at the moment when we see them, how long those symptoms have been going on. It includes, patients' family history, their social history, and all that comes with learning about that patient. And then next we turn to diagnostic imaging. So we want to see some brain imaging when we're seeing these patients, and that can be a CAT scan or CT, or it can be an MRI. And we utilize these tools to, again, not diagnose, because as I mentioned, this is more of a clinical diagnosis, but we do use it to rule out other pathology. So looking and comparing other diseases. And then we also use it to evaluate for any patterns of atrophy, which is shrinkage of brain tissue. And so that can sometimes just help lead us in a direction that could be down the road of FTD. And so the next step in the workup is doing some lab testing. And again, this is primarily to rule out other pathology. And so this, this could be vitamin deficiencies, it could be metabolic derangements, infections, and things like that, that we're really looking for to rule out for causing the symptoms that patients present with. And lastly, something that is really helpful, but isn't always obtained or able to be obtained even before patients are seen by a specialist, is neuropsychology testing. And what this does, it evaluates different measures of cognitive function, and it can aid in determining the presence of FTD based on a patient's testing performance. And I really can't go into a whole lot of detail regarding neuropsychology testing. That's not my specialty, but I do order it a lot on our patients, and it can be very helpful when we look at the scoring and what's being fully evaluated on those patients. And so if these workup items aren't obtained prior to being seen by a neurology clinic, that's just excess time that we're then going to be spending doing these investigations. And so that's, more time waiting on tests to be scheduled, more time waiting on lab results. And then just like with neurology specialty and many other specialties, neuropsychology testing is scheduling out very far as well. And so that's just one more thing that patients are waiting on for us to reach a diagnosis. And so really, these are all just further delays in that diagnosis that we really want to get for these patients and their families so that they can ultimately start planning and discussing and determining, what the next steps are. Really, ultimately, this workup doesn't necessarily give us that diagnosis, but it does help us to determine if a patient meets diagnostic criteria for any of the various FTD variants or ultimately another type of dementia. And so this workup ultimately can shorten time to diagnosis. And it's really why we do, hope and want to put, this information in the hands of primary care providers so that they can be starting down this road of workup before patient is ever seen by a specialist. So.
Thank you so much, Sara. I even have questions for you, but let's keep moving on and then we'll open up to questions. Our last but not least panelist that I want to introduce is Dr. Beth Prusaczyk. And Beth is an assistant professor at the Institute for Informatics and in General Medical Sciences, also like me at Washington University School of Medicine in St. Louis. And her research focuses on improving healthcare and social services for older adults living in rural areas, especially vulnerable older adults, such as those with dementia. And we're really excited to have her here today to share, a little bit about her background and her research focus. So Beth.
Thanks so much, Andre. And thanks everyone for joining us this afternoon on a beautiful afternoon in St. Louis. For those who are here in person, it's quite lovely. I know I am the last speaker in between us and the audience questions, which I know all of us are excited to get to. So I will be brief in my remarks. And just to start giving you a little bit of background, as Andre said, I am a researcher at Washington University, but I am a social worker by training, and I grew up in rural Southern Illinois, which is where my interests and my passion for rural health really comes from. And when I was getting my master's in social work, that's when I became interested in older adults and helping them with their needs in the community. And then as I went on for my PhD, that's when I became interested in specifically dementia and how can we improve the services that those living with dementia receive in these rural areas where I'm from and where all of my family still live. So currently my research is funded by the National Institute on Aging, and I have a 5-year study specifically to look at how can we improve the care coordination between the social service providers who are providing these really important dementia related services in these rural areas. And this study is really exciting and special to me because I am conducting it in Southern Illinois, where I grew up. So I really love being able to give back to the community where I'm from. I will just give a couple brief remarks over what I've learned in my research and what I'm still learning. I'm in year 2 of 5 of this study, so a long way to go. But I think the first insight, which shouldn't come as a surprise to anybody on this call likely, is that there are just simply not enough services available in rural areas for anything, dementia, cancer, everything. There's not enough services. So I think any chance we have to advocate, to lobby, to ask for more resources, more services, more funding for rural areas. We're always going to need that. I feel like I would never present on rural health without asking for that. So we always need more services. We need more funding. We need more resources. But I always take the approach that until we get there, until we have all the adequate resources and services we need, we've got to sort of do the best with what we have. And that's where my work as a social worker and my research comes in is, okay, how can we help the providers who are working in these rural areas better provide the services? They're providing services on shoestring budgets with a lot of challenges. So how can we help them provide services that will ultimately help those living in the rural areas with dementia, their caregivers, their families? And the few things that I've picked up from working with these providers so far in my study, first is that we have to rethink how we connect these providers in these rural areas, because the physical locations of these agencies, of these organizations, are so spread out that it's not always clear to the providers who else in this large geographic area is providing services. And I think if you're a provider on the call today, you know how easy it can be when you have a direct contact at another agency, at another organization, who you can pick up the phone and call and say, hey, I've got this family or I've got this client who needs this. And, that personal warm handoff to another service agency can just really get things moving much quicker than if you sort of have to go into the queue, put in a referral. And so in an urban area, you really will be working closely with these individuals. Maybe they're in the same hospital, where you have a desk. But in rural areas, they're so spread out that the providers I've been talking to have really been saying, I don't know who's providing services 20 miles away, but that's where my client lives, or that's where my patient lives. And I'm just not there. I'm not in that community enough because of the geographic distance that I don't know who's providing those services. So just really knowing who's in the geographic area is a big challenge for these rural providers. The other piece that I think is a little different in rural areas and service provision is the what we call in research task shifting. And it's the idea that when you have a lot of providers and you have a lot of services, you can get really specialized. You can be a social worker who really only does 1, 2, or 3 things. And, those are your main priorities. When you're in a rural area, you're sort of wearing all different hats. And so it's somewhat hard to figure out what services a given agency or organization might provide. And maybe you don't know that, the child daycare is also the same place where the senior food box pickup happens once a month. So there's just a lot of what we again call task shifting in these rural areas, where you have providers who maybe are providing one little piece of a dementia related service or a senior related service. And you wouldn't know that because they're maybe housed in another an organization's building that has nothing to do with dementia or older adults. So there's sometimes a lot of difficulty in just understanding who's providing all of these different services, because everybody's got to chip in and everybody's got to wear multiple hats in these rural areas just to get the coverage that they need. The last thing that I think I hear the most often from the providers that I work with in rural Southern Illinois is just simply the challenges of eligibility for these services, because typically funding for public health or healthcare, if it's federal funding, it's usually directed to the state. The state then sort of funnels it out to the different either geographic regions in the state or the different counties in the state. And so to be eligible for services, let's say in Franklin County, Illinois, services that are provided or funded through, state or federal funds, you have to live in Franklin County, Illinois, because Franklin County has gotten, X amount of money to provide services for the residents in that county. Well, in a rural area, counties are large and sparsely populated. And so you might, as a social worker in a rural area, or as a nurse practitioner, or as any sort of provider, you might have a client living the next county over, and you don't know what services are available in their county. You don't know if they're eligible for the services in a different county, because you don't know the eligibility criteria for that particular service. So the thing I hear the most frequently from the providers I work with is, we don't know who else is providing services in this area, And we really don't know if the client who's sitting in front of us is eligible for any of those services, because there are just really detailed eligibility criteria that have to be met. And the providers are always asking for some sort of database or some sort of just list of, who's providing services, and specifically what are the eligibility criteria. So I think, again, going back to my first point about, if we have the opportunity to advocate or lobby for better rural healthcare and social service infrastructure, one of the things I think we need to be asking for is for there to be at least some sort of rethinking of the eligibility criteria for these rural services, because it's just not the same as in an urban area where, usually everybody lives in the same county, or they may, the eligibility criteria may be what they call a metropolitan statistical area, an MSA, which covers, a whole, here in St. Louis, it would probably cover the 3 or 4 counties that make up the greater St. Louis area. That's just not how it works in rural areas. So we just need to be asking for a little more leniency, a little more flexibility in the eligibility criteria for these federal or state funded services, just so that it can better meet the needs of rural residents. Because right now it's creating a lot of challenges from what I hear. And I will stop there because, again, I want to make sure we have plenty of time for audience questions or Andre's questions. And I see some questions coming in at the chat as well.
Thank you. Wonderful. And thank you to all of our panelists. Excellent job. For our guests here with us, we thought the best way for the questions would be on the bottom of your screen. There's probably something like a toolbar that has something that says reactions in it. And I don't know if you're familiar, but if you go to that reactions, there's a place where you can raise your hand. And if you raise your hand, then we can know that you have a question, and then we would ask you to come off of mute and ask your own question so that we can really hear your voices. And I see there's one hand raised. So I'm going to ask you to unmute, Robin, and let you ask your own question.
So I think it's a question some other people have. Like, I want to go to San Francisco and volunteer in a study. And the provider that's doing the study did say they have transportation assistance, overnight housing assistance, because it's 2 days. I have to do an MRI and some other tests the next day. And yeah, I've reached out. I actually sent a message to Bruce, the first speaker, because he is at UCSF. And I thought, well, he probably knows these 2 people doing the study, and he might get more action than I've gotten. I got 1 phone call in and no follow-up. But they want a 30-day advance notice. And I said, well, I could come May or early June, but I heard nothing back so far.
Thank you, Robin, for that. And yes, I would say, I mean, I'm sorry they haven't gotten back to you. I hope they will. Usually with studies, and other people on here, may be able to speak to this more than me. I know Debra advocates in the research space, and Beth, and anyway, but usually there's a study coordinator, depending on the study, that is the person to communicate with. So hopefully they can get that person in touch with you. But for those of you in rural areas that are interested in coming potentially to academic research centers or other places, often studies do provide transportation and other cost reimbursement, because we know that's hard. So did anyone else on the panel want to say anything before I move to the next question? Okay. Allison, hello. I know Allison. Can you unmute and ask your question?
Hi, nice to see you. And Sara and Beth, it's really fun. I just wanted to pipe in and say I'm delighted to hear your ECHO program is going really well. In Oregon, we have a similar problem with rurality. And so we're starting a new ECHO this summer, which is called a curbside, which clinicians, social workers, nurses, whomever can just call in and talk with our team and present their cases. They don't have to do the didactic. They don't have to go through lectures. It's just a curbside. So I'll let you know how that goes. And then for Sara, I'm just really curious about how you deal with issues around driving.
Yeah, Allison, that's a really good question, and kind of a difficult one to answer. Ultimately, it's patient by patient really, but safety is going to be the biggest concern with any patient that has dementia. And so, we have safety evaluations that we utilize. And so oftentimes if I see patients, their family has concerns about driving, I always ask the question, have you ever gotten lost while driving to familiar places? Have you ever been in any recent accidents and things like that regarding driving? And then also when we do cognitive testing, I really try to look at the executive functioning portion to see, are these patients able to, make these decisions that would be required with just basic driving tasks, being able to, identify if I can pull out in traffic or when it's appropriate to hit my brakes and hit the gas. We also here in Springfield have a driving test program through our occupational therapy department. And so we'll utilize that too if we have a patient that we really feel is not safe to be driving, but they are very adamant about driving. So sometimes we'll refer to that resource. The only problem we have with that here is that it's not covered by insurance and it can be kind of costly. And so that's a difficult, really burden to put on patients whenever we're telling them, listen, we just really don't think it's safe for you to be driving. And another thing I try to do, and I don't know, maybe this is the wrong thing, but I really try to help them understand where I'm coming from and why I feel the way that I do. And I kind of give them a scenario, how would you feel if this were to happen and you were driving? The other thing is you can also come from kind of a legal aspect, unfortunately. I really recommend because of these things that you do not drive and give them the explanation. And then I say, I do document this. And so my concern is that if you were to be in an accident and these records were pulled or whatever it may be, then that could go against you, legally. And so I typically, most people, even though they do get very angry, they do tend to understand where we're coming from with that. My concern and outside of the safety issue, whenever we talk about driving and we do take this kind of away from patients, unfortunately, is that they do have then kind of a loss of independence. And sometimes we can see a decline, in their functioning after, we tell them not to drive. So that is something that can be difficult with this population. So
Thanks, Sarah. And thanks for the great question, Allison. Robin, I see your hand up. I thought there was someone, Zoe, with a hand up previously, but I don't see her in the queue. And so Robin, do you have another question? Oh, there's Zoe. Robin, let me go to Zoe first because I thought Zoe.
Oh, now I can unmute. Okay. Yeah. Sorry. No, I was just wanted to briefly, I put it in the chat. I was just going to say I'm the primary SLP working in research at UCSF. And so I would be a part of most of the studies of interest that I think that Robin would be being referred to. I'm not a coordinator, so I don't, so I was just offering my email as a contact just to help support her.
Perfect. Thank you. Robin, I don't know if you could get her email out of the chat. Did you have another question? I think someone will ask you to unmute. Let's see. Oh, yes, you're unmuted now.
Okay, yeah, the driving thing is a big thing. So that sort of makes you not independent in society anymore. And I know that you can fight it with DMV if you think that you're still cognitively okay, but I didn't know if anybody knows more about that. And I didn't get anything from DMV. I just got the doctor telling me they're referring my name to DMV. So my daughter and I decided I can still drive around Chico, but like I'm supposed to go on a down to LA and on a trip, and all that's going to be kind of, it's the unknown that has to be worked out. But yeah, so the not driving thing and then she suggested I move to a closer city for more testing, and the thought of doing that was overwhelming.
yeah, I
Here
understand.
the whole emotions came up. So I just wanted to know what we know about the driving thing. That is a big thing. And I'm not like 80, I'm 67. And cognitively, I think I've been managing things. I did work as an RPT for 43 years and helped a lot of people. So I think cognitively, I still have quite a bit going for me and I can make good rational decisions, but I'd love to do those driving tests and whatever's out there to prove I'm still okay.
Absolutely. I can speak to that briefly, and then if Sarah or anyone else wants to say. First of all, it's state by state, the laws around driving. I think California, in fact, has some of the strictest laws from my understanding. I don't live in California, but generally both the OT evaluations that we often recommend for our patients and what the doctor said are recommendations. They don't have the power to unless they go through a state process. There's usually every state, or all the states I know of, have a form that a physician or even interested community members can fill out and turn in to your DMV or the license bureau, and then they process it and probably test you. And then they're the ones that ultimately say whether you have your license or not. I have heard it said, and I don't know if this is always the case, but I've definitely heard it said if your doctor recommends you don't drive and you continue to drive and you get in an accident, you know, you may be opening yourself up to some kind of liability. I mean, that's a question to understand at least. And so going to an independent evaluator is probably a really good thing. If you pass the test and they agree with your, you know, proposition that you're a safe driver, then you have some evidence that says, well, I'm driving, but I had an assessment and they said I was good to drive. But Sarah, I see you nodding. Did you want to add anything before I move to the next question?
Yeah, Robin is right. In our, where I'm in Missouri, if we have real safety concerns and patients continue to drive despite recommendations, then we do have a form we fill out that we submit to the DMV. But really, that's as far as it goes from our standpoint. I honestly don't know what they do if they reach out to the patient or not in Missouri. I don't know the answer to that. We do it also from a seizure standpoint sometimes because we have Missouri state laws about that as well. And so that's something I've done more than I have with dementia. Most patients that I see, once we discuss it further, they understand, but I completely understand the difficulty with being told that or recommended that. Like I said, it's a huge loss of independence, and that can actually cause backslide in most patients, and we see progression sometimes. Along with the concern is if you are in a rural area, which I think you kind of brought up, Robin, you're far from where you can have this testing done and all that stuff. And a lot of people in this region are as well. And so that becomes a whole nother issue as trying to get to where you need to go for your medical help and go through the testing that is requested. So.
Absolutely. Thank you, Sarah, for that. And I think Allison put in the chat, and this is true. Some places have OTs, not only that do the driving evaluation, but some work with patients on boosting skills to become, and continue and maintain what they can with the driving.
Andre, this is Sharon. I wanted to just jump in because there's a really interesting question in the chat that was popped up earlier. And somebody was noting that Sara had some really good suggestions for primary care doctors in terms of how to streamline the process to getting a diagnosis. And the question was if there's suggestions for the families themselves in things that they can also do between the doctor's visits, the visits with the primary care physicians, that can help to expedite getting a diagnosis quicker. Are there things that families can do as well as the doctors?
I'd love to hear from Sara, but maybe also from Debra's experience with that.
Absolutely.
Too. So Debra, do you want to start and then we'll hear from Sara? You're muted. You're muted.
Sara, go ahead and I'll follow on with you, please. Go ahead.
Sure. Yeah. Really being educated is one of the best things that patients and family can do. When I see new patients for referrals, I try to kind of explain my thought process and what my differential thoughts are on what diseases this could be. And then I really try to equip patients and family with good educational resources so that they can learn about these different diseases. Because one of the biggest things is the planning portion of the future with these diagnoses. And so the hard thing is that even once you reach a specialist, the amount of time they can spend with these patients and families is not very much time, unfortunately. And so that's what makes it really difficult. They don't always, because they have such a large patient volume, to be able to sit and spend the time to educate about these diseases one-on-one. And so I think equipping families and patients on where they can find the information and really encouraging them to read about it, providing them with educational handouts is something I also do. I'm lucky enough to be able to spend some more time with my patients than physicians are. But that's not always the case in a lot of practices. And I think that's a big barrier. But I think the education piece is huge, and something that patients and families can do in between waiting on testing or waiting to get into a specialist and whatnot.
I love that. And I want to hear from Debra's follow-up, but I would ask Sharon, I think too. Sharon, I'm sure one of the biggest resources if FTD is suspected is AFTD. Do they have recommendations somewhere on your website about things you might consider doing before getting into a specialist?
We do, and I really appreciate the comments and the suggestions that people are making around helping families to get information and educational materials early. It's part of why awareness is really the key here, helping people to realize that not all dementia is going to show up with memory symptoms. It might show up with behavior symptoms or language symptoms. And if people can find their way to our website, we do have tools there that folks can use. And most particularly, we developed this past year some diagnostic checklists, which are things that people can download both for the behavior changes or behavioral FTD and PPA. And they're two-sided documents. One side has the kinds of symptoms or the kinds of changes that a family member might be noticing. The other side has the clinical criteria. So in part, we're hoping that people will use these tools as family members to take to their doctors, take to primary care, take to others in their existing healthcare network, and be able to at least say, these are things we see that are happening. Can you help us to get to the next step, with that idea of at least making that referral? But in the meantime, they're also going to be exposed to other resources about understanding what some potential symptoms are, using the resources around how to manage those symptoms, even if they don't have a diagnosis, because we know that in that time of the delayed diagnosis, there's such a need for beginning to understand how to understand behaviors and how to start to adjust and manage so that things can be understood from the family perspective of what kinds of things you can do. So those tools exist as well.
Great, thank you. Debra?
Oh, yeah. I love everything that's been said already. Very important things for sure. But I think as I listen to that, that is probably going to be for the individual that probably has a little bit more access. And so I want to talk a little bit about access, because I think it's particularly important when it comes to low-income individuals and people of color. Number one, they have limited their barriers to access, first and foremost. They receive poor quality care, and ultimately, the bottom line, inferior health outcomes. So I think it has a lot to do with the audience. Who am I speaking to? Because if I'm speaking to someone that English is not the dominant language, well, then I'm going to need an interpreter, or perhaps I'm going to need brochures to articulate what they might want to do in terms of education, reaching out, getting support for themselves. So I think those things are very important to be a part of the discussion. So I say that to say that there are no cookie cutter answers in terms of how to support individuals. It depends upon your audience, because you're going to address perhaps a Black audience a little bit different than you will a higher income white audience. So you have to take those things into consideration when you are trying to share with someone what support looks like, because it's real, you guys. Digital divide is real. Everyone does not have access to a laptop or some kind of device that can just jump on and just read about what's going on in the different spaces, and not only read about it, understand and comprehend, because there's a difference between reading, of course, and comprehension. So I have to say that it is important. All the things that was said, very important, but we also have to be very sensitive when it comes to our audiences and who we are talking to and with in terms of support. Because what one group of people may need, the other may not need it. They might need something a little bit more different.
That is such an excellent point. Thank you. And I see heads nodding with the people whose heads I can see along with what you're saying. So I think that really resonated, Debra. Thank you.
You're welcome.
Oh, Sharon, I see we only have 1 more minute, right?
We are winding down on time. How does the time go so quickly? There are, I think a lot of people are thinking of other questions to ask. I appreciate the expertise of folks who are here. Andre, I don't know, do you have a last question for each of our panelists that you'd like to ask?
Is there time?
We can do maybe one more question, and then, well, we probably shouldn't really. You can tell I'm torn because I really appreciate all the knowledge that's here. I think being able to hear more in time about some of the best practices that people are learning through ECHO and through some of the other research projects that are going on about how to build that infrastructure, how to help continue to streamline the diagnostic process, especially where access is not easy, for all the reasons that we've started to identify here. But I am afraid you're probably right. We need to wrap up because we have another session following.
Okay, I have one more question for Beth, but we'll just have to do it another time. We'll do
it again. Maybe one last question would be, is there a central repository, a central place where people interested in this topic should know to go to continue to learn about resources or research that's tapping into issues in rural communities?
Beth, I think.
Yeah, I was gonna say, the only thing that comes to mind that's, broad would be the National Rural Health Association in RHA. They are at the front of rural health and do a lot of work in that space, both advocating for services and policy and everything in between. So really, if you need help with any topic related to rural health, the National Rural Health Association is a great resource.
Thank you so much.
Sharon, thanks for inviting us to do this. Thank you, Sara and Beth and Debra. Y'all are amazing. And anyway, we appreciated the opportunity to be here.
Excellent. And as do I. I really appreciate the panelists who are with us and Andre for facilitating, and for all of you to have interest in this topic, I think is really critical. And so Beth, I wrote that down because that's a resource I was not aware of until you just mentioned it. And I really appreciate it. So for everybody who joined us today, thank you so much. Thank you to the presenters. We do have another session starting shortly. So I hope that you'll stay with us through the end of the conference. And thanks very much. We'll see you all soon.